I was asked to sort of give a Sheffield view on oncology. It makes it sound like it's different from everybody else's. It isn't really, but there are one or two things that we maybe do differently, and hopefully we'll highlight them. So it's going to be a bit of a mishmash, I'm afraid, but we'll see how we get on, okay? As you know, all eye tumours are rare, and because of that, there are only the 4 places in the UK that look after them. 3 in England and 1 in Glasgow, who have their own arrangements in terms of funding. And what do we see? Well, strictly speaking, this will relate to the guidelines we talk about this afternoon, we should only be seeing adults with eye cancers, and it should be tumours or suspicious things, either on the interior of the eye or the surface of the eye. We're not really supposed to look after lids or orbits, but often there's a bit of overlap between the two. But we do work closely with orbital and oculoplastic colleagues, because obviously some patients don't read the guidelines and they have a bit of both. What do we see in Sheffield? Well, we get about 550 new patients per year, of whom about 140 will have a tumour of some sort, the vast majority being melanoma, of course. The other, about 50% of the patients that we see have moles, nevi, lumps, whatever you want to call them, and we monitor them. And the other 25% have something completely unrelated, a hemorrhage, a scar, sometimes even normal anatomy, and they get discharged. One thing we do in Sheffield is we follow our patients up pretty much forever until they get fed up. And so we do have a lot of follow-ups coming, about 2,500 per year. This is our team. You've always got to have a team photo. Some of you, if you've been to Sheffield, that's Ian Rennie. He was responsible for the Sheffield service 25 years ago. These 2 reprobates here, Rona and Leslie. Some of our imaging guys. Catherine here, who is the first point of call for our patients when they come to the clinic, organises the appointments. Hardeep, our pathologist, lurking in the background. And Karen, who's the Cytogenetics queen in Sheffield. So, these 2 in close-up. Rona and Leslie. Rona's cringing over there. I can see her out the side of my glasses. Rona and Leslie are our specialist sisters, okay? They may not look old enough, but they've got probably half a century of experience between them. And they're ophthalmic sisters, but they're also oncology trained. So they're there for you guys, really, for support and counselling and information and phone calls and party invitations, whatever you choose to throw at them. So what happens when you come to Sheffield? Well, the referral letter comes through to Catherine, or the fax comes through to Catherine. She will usually phone you to organise the appointment. If there are any obvious concerns from the letter, or if you know it's clear that you are, I'm talking about you, I'll stop saying that. If the patient is particularly anxious, then Rona and Leslie will phone them beforehand and try and discuss things in advance, or try and pre-book the test before you come to the clinic. You come to the clinic, hopefully we'll make the diagnosis there and then and discuss the options, but we always discuss patients at an MDT meeting. There are now 3 of us. One person I said I wouldn't forget, and I did, is Sachin. He's in there somewhere. He's our 3rd ocular oncologist, also does plastics and orbit. So the 3 of us and the 2 other plastics consultants meet up with our pathologist, Rona and Leslie, every week, and we discuss what we're going to do for each patient. And that's partly where Rona and Leslie are important, because if they've discovered more information from the patient after we've left them in clinic, they'll often bring that to the meeting. Sometimes it's things like, this person is particularly worried about losing their eye, or this person is worried because their father died of a cancer of some sort. And that doesn't always come out when you're discussing quickly in the clinic. So you can bring that to the meeting, and it allows you hopefully to plan things slightly better. From the meeting, we organise investigations and biopsies if one is thought necessary, then on to treatment, and finally, as I say, follow-up. We do follow all our patients up long term, unless they particularly don't want to come back to Sheffield. And again, the counselling and support is there in the clinic. Rona and Leslie are always in the clinic with us. So it's a circular process. A little bit of, you'll have heard some of this from Bertel last year, but just to reiterate, Freckles in the eye are very common, affect probably 5% of the population. Some of you will probably have them without knowing it. Whether they're present from birth or not, we don't know. They tend to get found when you start going to the opticians when you hit middle age. So they're very, very common. There's one. We do get sent these into the clinic. We probably shouldn't, but we do. But of course, at the other end of the spectrum are uveal melanomas, which are very rare. Should be around 500 to 600 cases a year in this country. The majority in the back of the eye, in the choroid, 20%, so in the mid-zone, only 5% on the iris at the front. As always, the main age group is 40 to 70, but of course you can be either side of that. I think the youngest we've seen is a 10-year-old, and the oldest is obviously something like 100. There's the beast, collastoid melanoma. Now, between those two extremes, you've got other things. You've obviously got small moles at one end, small nevi at one end, melanomas at the other, but there's no clear distinction between the two. You've got a range of lumps of different sizes going from the one end to the other. And it's what you do with those in the middle that's important as well. Some of those, of course, will be moles that have turning into melanomas, and many of them will never change. So I call them big moles. Prof. Rennie likes to call them indeterminate melanocytic lesions because it sort of sounds more impressive probably. But basically they are large or suspicious nevi, which in our opinion need monitoring. They often have a very moth-eaten surface to them, which is good because it shows they've been there a long time. Okay? So that's one. That was sent to us 10 years ago as a melanoma. It's an enormous lump in the back of someone's eye. But it really does have a moth-eaten look to it, and that hasn't changed in those 10 years and it hasn't needed any treatment. But a lot of those follow-ups that I talk about are things like that. Okay? So how do you tell the difference? Is that a mole or is that a melanoma? Well, there's a checklist, sort of a mental checklist of five or so features rather. And you go through and decide which they've got. The orange pigment is probably the most important. These other things, symptoms and subretinal fluid, are less so. And then obviously the size is important at the bottom. Now then, we looked, because we've been following so many moles for so long, we thought we'd better review some of them. And 6 years ago we did a review of the large moles that we'd monitored. And out of 240 which we'd followed for more than 5 years, we found that less than 5% of them grew, which was reassuring. And that 5% of people were treated as melanomas, but fortunately, none of those patients developed metastases. So it's reassuring to us to know that by monitoring people who may be melanoma, we're not doing them any harm. Okay? This is what we mean by documented growth. Here's a chap who had a small melanoma, very small but clearly a melanoma. It's got the orange pigment, fluid, symptoms, he's got blurred vision. I'll tell you now, we wanted to treat that, but he refused. But it didn't actually change for 18 months. But when it did, it doubled in size between one 6-month visit and the next. Okay? So, cut to the business end. What are the treatment options? Prof. D'Amato, I think, covered all the treatments in detail last year. There are lots to choose from, ranging from doing absolutely nothing, which sometimes patients prefer, through to an exenteration, which is about as major as it gets in terms of clearing out the socket of all of the contents. I'm just going to talk about proton beam because it's a nice treatment, and those of you who've not had it might be interested to hear a little bit more about it. Proton has been around for years, more than 20 years, and it utilises charged particles produced by the cyclotron. There's one of those in the country at the moment, and that's over in Clatterbridge. But all 4 centres use proton beam, and what it requires is insertion of these little tantalum titanium markers onto the eye to localise the tumour. Then the patient is sent over to Clatterbridge with all the data that we've collated. A treatment plan is produced, and then once that's been signed off, the treatment is delivered in Clatterbridge. So there's a bit of toing and froing. It's not a terribly good picture. This is from a textbook. but this shows you what we do in surgery. You'll not have seen it from if you've been involved with surgery, you'll have been asleep at the time. But what we've done here is put a light onto the front of the eye, and the eye glows, and the tumour is outlined as a shadow. So you join the dots, draw around it, put the 4 clips on, and then take the measurements from that. Okay, and that's the data that then goes off to Clatterbridge. So it's actually quite straightforward, really. Put a light on the eye, draw around it, put the treatment on top. One other thing I know you're going to ask questions on, so I'll have to spend a lot of time talking about Stereotactic now. Stereotactic is only available in Sheffield. It's something that Ian developed years ago. We happen to have this instrument called a gamma knife in Sheffield. It's mainly used for brain tumours, but Ian realised, as I say, 20 years ago, that it could also be used for ocular melanomas. For some reason now we've got 3 stereo units in Sheffield. We've just replaced one because it was getting a bit long in the tooth, and there's a third private one up the road which we don't use. But what it involves is it has 200 separate cobalt sources, radioactive sources, built into a hemispherical array, okay, a bit like a dishwasher, and each of these is focused onto the tumour. So you've got lots of individual weak beams, if you like, producing a very high dose on the target. So it's a bit like using a magnifying glass, okay? And hopefully by having a highly focused beam of radiation, it causes less collateral damage. This is why the neurosurgeons like it, because they can treat very deep-seated brain tumours without damaging everything else around about. And in theory, with this, there's no upper size limit, but in practice there is. So there's a schematic, there's a picture of like an MRI scan of someone's brain. This is the eye socket, and you can imagine all these beams being focused onto the tumour there. Okay? That's the first machine we used. As you can see, it is a bit like a dishwasher. The sources are housed in here. The patient is on a couch which slides into the machine, and this is a collimator with the individual sources. When it goes in, these guide the beams, if you like, from here onto the patient's eye. And each one of these can be plugged to produce an individual pattern of radiation for the patient. We don't have to be too fiddly with ocular melanomas because they tend to be pretty much round or dome shaped, so you don't have to be too fussy about the plugging. But the idea is that the patient is fed into that to receive the radiation. Now, because you're trying to treat a very small target tissue, the patient has got to remain still. I've got a horrific picture for you in a minute, so brace yourselves. What it involves is a frame is attached to the patient's head, which is fastened to the couch, so you can't move your head, and the patient's eye is immobilized with an anesthetic injection, so everything is pretty much stable. Okay, so horrific picture time. There we are. This is a stereotactic frame. Okay, you'll be pleased to know you do get anesthetic here. All right. Most people have photographs taken of themselves when they're wearing this, and I think it's then passed around the dinner table at home to show what they've been through. But the eye has been immobilized, the frame has been applied, and as you can see, there are markings on the frame, and the idea is when you do the MRI scan like this, these are markings from the frame, and you can essentially work out the coordinates of the tumour in relation to the frame. So when the frame is bolted into the machine, if you know where the frame is, you know where the tumour is, so you know where to fire. So this is a chap that treated 2 days ago in his right eye. It's with an MRI scan, you're looking from the feet upwards, so this is like looking up to the right eye and the left. Just zoom in a bit, it's gone a bit grainy because it's not intended to be magnified. There's the tumour there, and these are the radiation contour lines, the plan that has been put around that tumour. Okay? Once you've had the MRI, the patient is whisked off to the machine, and it takes between 20 and 40 minutes to do the treatment. Okay? So I'm going to do the disadvantages of stereo first. One thing is, it's not very pleasant having an anaesthetic under the eye. Most people manage very well. The frame can be uncomfortable. Okay? So once you've got over the initial shock, it's pretty much manageable for most people. Because you've got radiation coming in from the outside through the front of the eye, the front of the eye does take a dose of radiation, and like all forms of radiation like that, including proton, the front of the eye can sometimes be upset by the radiotherapy, okay? But the advantages are, it's quick. I often sell this to patients as a quick fix, if you like. It doesn't need a general anaesthetic. If you've got perhaps an elderly or infirm patient who can't manage a general anaesthetic, provided they can lie still for 20-30 minutes, they can have stereotactic, okay? Some people don't want the palaver of travelling over to Clatterbridge for 5 days, having a general anaesthetic. They may not want to be in hospital with us having a plaque in for 4 or 5 days, okay? So, you know, it may not be top of the list for most people, but not having to stay in hospital is a big winner for some patients. The chap I treated the other day could have had any of the radiotherapy techniques, but he didn't want to be away from home, so he's had stereotactic. And overall, it works as well as all of the others. It's about it's more than 90% actually, in terms of local control. So, over the last 20 years, we've treated 170 patients. Might not sound many, but initially we only used it to treat tumours that were really too large to be treated by other forms of radiotherapy, and in patients who didn't want to have their eye removed, okay? So at the beginning we treated tumours which were really quite difficult to treat, okay, in other ways. But over the years we've refined it and gradually reduced the dose that we use. So initially we started off with a dose of 70 Gray, which came from animal studies, found out that it worked. The Germans do a lot of this as well, and the dose was gradually reduced, still seemed to be working well, and now the dose is down to pretty much half what it was originally. As you see, that lot doesn't add up to 170 because 20 patients' notes weren't available. But what we found was that even though we've reduced the dose over the last 20 years, the local control rate in terms of tumour recurrence has stayed the same. So reducing the dose has not led to any more failures, okay? But what it has done this last 10 years or so with a lower dose, vision is better than it used to be, and the eye retention is better. So basically, there are less complications with a lower dose, but without, with no sacrifice of control, okay? So nowadays, there's about a 40% chance that the patient will lose a lot of vision in that eye. Now that might sound a lot, but you've got to remember that these tend to be tumours that are right next to the optic nerve and all the important clockwork, okay? So that is actually better when we reviewed it than I thought it was going to be, okay? Rubiosis is quite a severe complication that can occur with any radiotherapy, and I've thrown that on as 8%. It used to be 25% when we used the higher dose, okay? But this is manageable. So, a couple of, you always have to see the good pictures before we, can I do the question? Do you want to do it now or the question at the end?
Sorry, just go through the S's.
I'm going to show you a picture. 2 secs, sorry, yeah. Got to see the successes first, okay? Here's a patient, large melanoma, the optic nerve is just about there, okay? Very close to the nerve, so I personally wouldn't want to put a plaque on it. Had stereotactic rather, and a year and a bit later, the tumour has gone. Starting to show a little bit of when I turn away, can you still hear me?
Yeah.
It's not fading in and out. It's very irritating when it does that. A little bit of radiation damage showing, a little hemorrhage there, okay? But at the moment, still got drivable vision, okay? Another one, a little bit more subtle. It's not showing up terribly well there. Small melanoma there, right next to the nerve, right into the macula. That's the central part of the retina that you're all using at the minute. And after a year, regressed. A lot of vision loss in this person, but it's to be expected, okay, because of where it is. Final one, showing a few of the complications, if you like, you can get from these. Again, large melanoma next to the nerve, a lot of orange pigment, doesn't seem to be showing up as orange from where I'm standing, but hopefully you can see that it is. After the radiotherapy, it's regressed, the orange has gone, but this is radiation damage to the optic nerve, okay? So it's not a light-hearted treatment, but it works, okay? Answer your question, rubiosis, horrible picture. Rubiosis is a complication that can affect any sick eye, okay? So if you've had a thrombosis, diabetic problems, say, anything wrong with the circulation, if the eye is sick enough, What it does is it produces chemicals which causes the blood vessels to be replaced, if you like, to grow new blood vessels, which sounds like a good idea, but it's not, because they grow in the wrong place, okay? And if they grow on the front of the eye, they can make the eye painful and put the pressure up, so that's called rubeosis, okay? You would rather not see that, but I'm afraid you do still see it occasionally. So, that's stereotactics. You can also say you've got 5 now, okay? Everyone has to put 5 for the after bit of the assessment. A little bit on cytogenetics. Karen Sicily, who showed you at the beginning, as I say, is the queen of cytogenetics in Sheffield. She heads up a research lab with 7 researchers now, and she identified some of the genetic abnormalities which you'll all know about now back in 1990. They first identified them just looking at melanoma cell lines. By 1997, she'd worked out that this correlated with the prognosis. So monosomy 3 and multi-8 chromosomes are associated, as you know, with a poorer prognosis, and she reported that in 97. And in 98, Ian reported his use of transvitreal biopsies for melanomas. So we've been doing it for 20 years plus. Where we probably, I think Sarah's going to tell us about it later, what the advances in cytogenetics later on. We do it slightly differently in Sheffield. If someone's having their eye removed or the tumour is being resected locally, so we've got a bit of tissue, the genetics will be done automatically, okay? What we don't do is biopsies if we're using a conservative form of treatment. So if I was going to do a plaque treatment, let's say, I wouldn't routinely do a biopsy, okay? Other centres think everyone should have a biopsy. I've never felt that was desirable, okay? But what I do is I say to folks, we have a test and it can tell you whether you've got a good melanoma or a bad melanoma, okay? The reason I don't like to do it is because it complicates the surgery to some extent, okay? You're converting what was an extraocular procedure going into the eye, which is one thing. But it doesn't actually alter how we would manage you as a patient, okay? The way I look at it is everybody should be screened for metastases, all right? And how you do it is another bone of contention. We advocate 6-monthly ultrasounds. And so whether I think you've got a good melanoma or a bad one, I'll want you to have 6-monthly ultrasounds, okay? So that's my rationale for not pushing a biopsy if you're not going to take tissue otherwise, okay? And, we can discuss it all day if you like, but that's the way we do it in Sheffield, okay? Whether you can get the scans done is another matter. I could show you a letter that I've got there from a GP saying, why are we asking to do these? What's the evidence? Who's going to pay for it? The radiology department says that it's not indicated. And I find myself more and more having arguments with commissioners and things. So it's getting to the stage where we just try and do them all ourselves, all right? Rightly or wrongly. Anyway, that's a hobby horse I'll climb off. Oh, that's telling me I've got to shut up, clearly.
Sorry, can I start? Is that too dark now? Is that better?
That's better.
It's better than it was. Okay, good.
Shall I start again? Anyway. So, I always like to show this slide, this Larson cartoon. A lot of what happens in medicine is not rocket science, and that's the same with ocular oncology. A lot of it is pattern recognition. You probably know what it's like. You walk into the clinic, you get told it's a melanoma. How do you know? Well, because it looks like a melanoma. And I'm not being flippant there, but a lot of it is pattern recognition. But what is important is that it's a team approach, okay? You've got the ophthalmologist, the imaging, the pathologist, and, as I said before, one of the most important aspects is, the support and the counselling afterwards. So I think it's that team approach that makes UK ocular oncology as successful as it is. So I'll leave you with that. Thanks very much. How do we determine what treatment to offer any one person? You can't be didactic about it, okay? Essentially, the first thing you do is you look in and say, can that eye be saved? Okay? Is it an enucleation or not. After that, size comes into it, all right? There are 3 forms of radiotherapy available there, as you saw. My personal preference, and I think that's probably true for most ocular oncologists, is for a plaque. If you can put a plaque on and the patient's fit for surgery, then a plaque is probably my favourite treatment. Plaques, in theory, can only treat up to 6 millimetres thick. You can go a bit higher, on the continent they go a bit lower, but so size comes into it. Then it's location. If the tumour is very close to the optic nerve, so that I wouldn't feel confident to actually try and put the plaque next to the optic nerve. You can't pop the eye out and put it on and put it back in. And then finally, you get into things like patient choice. Do they want to be away from home? Do they want to general anaesthetic? What's their health like? So you can't be too prescriptive. You've got to sort of sit there and say, these are the choices. Now, I must admit, some patients don't want choices. They want you to say, you're going to do that. You know, so sometimes you can get it wrong, if you know what I mean. You know, some patients want to be told, others want to mull it over. Is there not a case for doing more biopsies in order to produce a cohort of patient data, if you like, for research? That's true, okay? I still look at the individual, okay? I mean, we produce, we've got a bank of several hundred melanoma cell lines on which genetics is done, and we've got the follow-up for that. The question is, would I put a patient through a biopsy? I'm not saying put it through, they may choose to. If they choose it, we'll do it. For the sake of mankind as a whole, as such, okay? I will do what patients want me to do. The way I look at it, I can't speak, you know, if I'm speaking for you guys and you disagree, that's fine. But if it's not going to alter what I'm going to do for you as a patient, then I wouldn't push to have it done. I know what you're saying. I think when it gets to the point, I could be cheeky, I suppose. I could say, let the other guys do the research. When they've got the prophylactic treatment, and that's when I think we really need to know, of course, who's got a poor prognosis. When you've got a treatment that you can give, bang, right at the beginning to reduce the then of course everybody will have to have a biopsy.
Presumably there's a sort of catch-22 then. Would they be arguing, I don't know, would researchers be saying, well, we need that information to develop?
I know.
Is that what's happening?
Well, it does, but the catch-22 as well at the minute is some people say, you've got a poor prognosis, it's not worth screening you because you're going to die. You know, and it depends how you want to approach it. You know, you could say, sorry, you've had a biopsy, you've got a monosomy 3 multi-AQ, you've got a very poor prognosis, I'm not going to bother treating your eye, let's save some money. Do you know what I mean? You can throw open all sorts of cans of worms.
Sarah.
Oh dear, here we go. It's down to patient choice, okay? At the moment, you're looking way down the line at drug trials, okay? For most people that I talk to, they actually refuse a biopsy. I don't say to them, you can't have a biopsy. At the moment, it doesn't alter what we do for them, okay? Now, if we get information in the future that would be a benefit in that situation, then of course we'll do it. But at the moment, I wouldn't put 140 patients a year through a biopsy in case they could be enrolled in a trial in the future. I think it's changed over the years. You know, when we started, we didn't talk about doing biopsies at all. Partly as a result of the work of you guys, I do now give a bit more information. We do talk more detail about biopsies. A few years ago, we didn't. Okay, it wasn't our policy. It didn't seem, well, being again flippant, it didn't seem important at that time. Do you know what I mean? But the information's out there now, so patients do have to make an informed choice. The difficulty with that, of course, is the choice that a patient makes is often steered by the way it's delivered. You know, you can tell my approach to biopsies, so I may lead people down a particular way inadvertently. Do you know what I mean? If I came in and said, you must have a biopsy because it could provide you with data in the future, then everybody would take it. At the moment, I'm unconvinced that everybody does need one, okay? But yes, the trouble with informed consent, of course, is knowing how much people want at that time. You can't backpedal.
Yeah, all you can do is ask them how much they want to do.
True. But it varies a lot from, do you know what I mean? You can ask them how much they want to know, and people will often say yes, but then you give information out, and all of a sudden you've crossed into too much and the shutter's come down. You can see it in front of you. And Rona gets that all the time in clinic. And that's partly why we try and give what we think is appropriate. I know it sounds very paternalistic. You try and give what you think is required at the time, and then it's followed up by Rona and Leslie. And if more information is needed later on, we can give it. You can never